Hyponatremia is always a difficult thing to work upon. That said, amongst them, patients of SIADH, that is those who have syndrome of inappropriate secretion of ADH versus cerebral salt wasting, are especially difficult to diagnose. Both of them are going to have low sodium. Both of them are going to have high urinary sodium and high urinary osmolality. That means both of them on the biochemical markers might look very similar. Add to that, both of them could have cerebral insults as a preceding cause. However, there is one difference that really helps. Remember that SIADH is always euvolemic. That means the patient's volume status is preserved. On the opposite, cerebral salt wasting typically has hypovolemia. In fact, cerebral salt wasting also has patients typically having a slight amount of polyuria, which is missing from SIADH. So if you get a patient of subarachnoid hemorrhage, if you get a patient of TB meningitis, or anyone with has a cerebral insult, and along with that has hyponatremia, look at whether the patient is having polyuria, having features of volume loss, and in that case, that patient should be thought as cerebral salt wasting. You should not restrict his fluid intake as you do in SIADH, rather give him sodium and fluid both. I hope this helps you a little because these are confusing topics when you're working in the emergency department.